Good afternoon, and thank you for joining us today for the many faces of breast and ovarian cancer in partnership with Baraka Strong. We have an excited panel of experts lined up for you today, including Dr. John Diaz, Dr. Lauren Carcas, Dr. Alvaro Gomez, Dr. Arelis Martin Negron, and Dr. Sarah Joseph. We encourage you to submit any questions or comments via chat as we will be having a Q&A session with the panelists after their presentations. Following today's program, we will send a short survey. Please take a few minutes to respond and share your ideas so we can continue planning programs that are meaningful and impactful. Now, I would like to introduce Tracy Milgram Postner, founder of Baraka Strong, to share a little about this important organization. Tracy?
Good afternoon, welcome. Thank you so much for partnering with Baraka Strong and being one of our sponsors to continue to make a difference in the community. Baraka Strong strives to alleviate the emotional and financial burdens of women with breast or ovarian cancer, regardless of predisposition. We're here to help you eliminate the feeling of isolation and help you feel whole again. We do that by sending out pre-mastectomy care packages, which include 2 post-mastectomy pillows, a robe with a drain holder, and a post-mastectomy garment, as well as we have surgery kits for women who are having hysterectomies or other kinds of cancers. We're here for you to support you and guide you through your journey. Thank you so much for having us part of this panel today. And I would like to introduce Dr. John Diaz.
Thank you, Tracy. Thank you, everyone, for joining us today. And I think this is a great event. We got together really an outstanding panel to talk a little bit about ovarian cancer, breast cancer, and what we can do to help try and identify these cancers early. And once identified, what we can do for the treatment of these various cancers include, partnering with other professionals in our field, like Dr. Gomez from cardio-oncology, as some of these medications may have cardiac toxicities. So I'm going to take just a moment to talk briefly on where we are with ovarian cancer. So one of the questions that I often get asked is, John, what can we do as far as screening for ovarian cancer? And people ask about an annual GYN ultrasound or the blood test, which is the CA-125 test they're referring to. And what we want is to find a test that's going to help us identify a cancer either when it's pre-malignant or an early stage when we can intervene. And right now for ovarian cancer, that doesn't exist. So the most important screening we can do for ovarian cancer is getting a family history. And through that family history, seeing if we can identify those women who are at increased risk of carrying a genetic mutation. And if we can identify those women and those families, then we have the ability to potentially intervene before the diagnosis of ovarian cancer. So really the best screening test is to get a family history. And when I speak with my colleagues and my friends, I talk about how important it is that check family history every visit. Family history changes, it evolves. When we meet patients, we educate them on what are they supposed to ask of their families, not just that Abuelita had a cancer, but what kind of cancer did Abuelita have? When was she diagnosed? Was there anyone else in that family? And that's really the best screening that we can do, is try and fine tune that family history, try and identify those patients that may have a familial risk of one of these breast and ovarian cancer syndromes. And if so, then send them to someone like my partner Arelis, who you can hear for later, about the importance of genetic counseling and the appropriate patient's genetic testing. And if we can identify these women and we can intervene before the onset of ovarian cancer, that's really where we can make the biggest impact. So specific to screening, again, I get a lot of questions about GYN ultrasounds and CA-125. And despite our best efforts, these things really haven't proven to do what we want. And what we'd like them to do is we'd like them to identify an ovarian cancer when it's an early stage and it's treatable and potentially curable. And they've done lots of studies looking at what's called routine GYN ultrasound. So you go to your GYN or your family practice every year and you get an ultrasound just to check and make sure everything's okay. And unfortunately, that really hasn't translated into an ability to identify these cancers earlier. Now, in a specific high-risk group of women, so women who perhaps carry a genetic mutation that puts them at increased risk, in those patients, there may be a role for using a combination of GYN ultrasounds and CA-125 to identify those women. But even in those patients who have a much higher risk of developing ovarian cancer, it really hasn't been able to translate into potentially identifying an ovarian cancer early. There was a recent trial out of the UK that did show some promise, and it did show that those women who were in these screening programs and were in these high risk, that potentially this combination may lead to identifying an earlier stage compared to women who weren't in a screening program. So we do offer this to our patients. It's the best tools we have, but by no means is it as good as screening mammography, pap smears, or colon cancer screening. So it's the best tool we have. We use it, understanding its limitations, and understand the women who derive the most benefit are high-risk patients who are at genetic risk. Really, at some point, we have to discuss the potential role of a risk-reducing surgery. And again, the idea there being is we're removing a healthy tissue, like the ovaries, the fallopian tubes, or the uterus, depending on what cancer we're worried about, and we're removing this healthy organ before the onset of cancer. And that can be difficult for patients to come to terms with, and that's understandable. And it's something that really needs to be discussed at length for them. It's not just a one-time visit to talk about what are the benefits of preventing this cancer, but what are some of the downsides? And together with shared decision-making, understanding the risks, the benefits, you come to an agreement. But that's the best strategy we have for reducing the risk of ovarian cancer. Now, once you're diagnosed with an ovarian cancer, that can be a difficult diagnosis. Most women diagnosed with ovarian cancer are diagnosed at an advanced stage. But over the last couple of years, we've really had a breakthrough in the management of ovarian cancer. And that breakthrough comes through in the treatments that we're using both upfront in chemotherapy with combinations of traditional chemotherapy, and in some cases, a medication called bevacizumab, which is a VEGF inhibitor. The biggest breakthrough has really come through with a new class of drugs that are called Parp inhibitors. And so Parp inhibitors are an oral medication that patients take at the completion of their chemotherapy based on either do they carry a genetic mutation, does their tumor have a certain genetic profile that would make them more responsive to Parp inhibitors. And again, the idea of shared decision-making is this new class of drugs going to help prevent your cancer from coming back. And that's been one of the biggest breakthroughs that we've seen in ovarian cancer over the last years. And this drug started as a treatment for women who had recurrent disease. We've slowly been able to move it up for patients with recurrent disease, and now it's part of the standard of care really in the upfront therapy. So all women who are diagnosed with ovarian cancer, it's really important to get them to see a genetic counselor, undergo genetic testing to see, do they carry this germline mutation, one of these BRCA mutations, which would really change the way in which we treat them. And then we also need to examine their tumor. Does their tumor carry some kind of profile that would indicate that they would benefit from these Parp inhibitors? And what kind of maintenance therapy to triage? So that's been one of the biggest breakthroughs that's really improved the survival for our patients. Another breakthrough that we've been looking at, it's not really an old treatment, but it's a treatment that we've kind of reintroduced. And it's something that's called hyperthermic peritoneal chemotherapy. This chemo bath that we've incorporated at the time of surgery, and those patients who were able to remove all of the cancer at the time of their cancer surgery, we then circulate this hot chemo bath. And that's been shown in a randomized controlled trial from the Netherlands to improve the survival for patients who have ovarian cancer and peritoneal cancer. So that's something our practice has been doing since 2012. And we use this combination both at the time of recurrence in the appropriately selected patients, as well as at the time of initial diagnosis. And that's something that we have a lot of experience in. And then the concern is, okay, what's coming down the pipeline? What are the new emerging things that we have? So one of the nice things at our institution is we have a pretty robust clinical trials program. And so right now we have several clinical trials looking at women with ovarian cancer who've had a recurrence and trying novel medications to see where this fits into the treatment of ovarian cancer. One of the new types of drugs that have been very exciting are these drugs that are called ADCs. And the idea is kind of like a Trojan horse. So these drugs, they come and they're enveloped inside an antibody that will then bind to the surface of your ovarian cancer cell. It then gets brought into the cell, and that's where this kind of opens up and delivers its medication, its payload right there in the cell, leading to cell death, not only in that cells, but the neighboring cells. And we have two trials looking at two different drug conjugates that have been very exciting. These are both phase 1 and phase 2 trials. And I think it's so important for women with ovarian cancer to have access to these clinical trials. That's how we move the science forward. That's how we improve outcomes. When I talk to my patients about PARP inhibitors, I let them know that when I was a first-year fellow at Sloan Kettering over 14 years ago, we did the first phase 1 trial looking at PARP inhibitors. And it's taken 14 years to bring that phase 1 drug now to market to where it is today, where it's part of the standard of care in the upfront setting. So these advances that we make through clinical trials are so important for patients and for patient outcomes. And it's been shown time and time again, women who are on clinical trials do better, whether or not the drug ultimately becomes part of the standard of care. And the reason is you get a closer eye. You have an entire group of people now looking after you when you're on clinical trials. And those physicians who are involved in clinical research tend to be some of the more cutting edge physicians in that field. So even if you're not in a clinical trial, but you're being treated by a physician who's involved with clinical research, data has shown that those patients have better outcomes. And so I think that's one of the really exciting things going on here at the Miami Cancer Institute. We've really changed the way in which we treat ovarian cancer. We have a robust clinical profile for our patients with ovarian cancer to really improve their outcomes. And so I think I've given a brief overview on where we are with ovarian cancer. It really has been my pleasure to partner with some of the people you're going to hear later today. We have a very close working relationship with our medical oncologists, a very close working relationship with our geneticists you're going to hear from. And one of the nice things about being a center like this, and we're the largest cancer center in the state of Florida, is you have access to all of these resources under one roof. And I think that really has made a difference in the patient experience here in South Florida. So I'm just about out of time, but thank you so much, Tracy, for inviting me to speak today. And I think we have great panels, so I'll make sure I'm respectful and give everybody's time to hear from them. So the next person I'd like to introduce is my friend and also my colleague here up in Plantation, one of our new sites for Baptist Health. Dr. Lauren Carcass is a medical oncologist who specializes in breast and GYN cancers. And it's a pleasure to work alongside here in Plantation. So Lauren, take it away.
Thank you. And thank you everybody for having me. And thank you, Tracy, for this invitation. I always, one of my passions is teaching, and I'm going to go through a little bit today, some of the things that I find that when a patient's newly diagnosed with breast cancer or really any cancer, these are the questions that come up. Number one, what is cancer? Number two, why did I get it? And number three, what is my stage and what are my options? So I always explain that, number one, what is cancer? Every cell in our body has a job to do. And it goes and it does that job, and then it replicates itself, and then it's programmed to die. And if for some reason that cell loses its signal to die, whether it's a genetic predisposition, whether it's an exposure of radiation, whether it's excess hormone, whatever that cause may be, that cell becomes immortal. And one immortal cell makes two, and two make four, and four, it keeps multiplying. And where that tumor is located is really how we define what cancer is. If we think about cancer of the breast is basically a highway of milk lobules and milk ducts that culminate at the nipple. The lobules are closer to the chest wall side of the breast, and that's where the milk is produced. And then it courses down through the duct to come out the nipple. If you have a cancer of a lobule, it's called a lobular carcinoma. If you have a cancer of a duct, it's called a ductal carcinoma. And if the tumor cells, once that tumor cell continues to grow, if it grows inside the duct or the lobule and does not invade beyond the wall of that duct or lobule, we consider those to be a precancer. Then it would be a lobular carcinoma in situ or a ductal carcinoma in situ. And that's really a stage 0 cancer. That's basically, if you were to cut the breast this way, what you would see is these tubes like this. And where my skin is are the normal ductal cells or the normal lobular cells. And if one of those overgrows, it can overgrow to fill in the inside of that tube like this. And that would be an in situ carcinoma. That's stage 0. But as soon as those cells overfill the inside or invade beyond the wall of the duct into that fatty tissue, that's when it becomes an invasive cancer. And an invasive cancer in the breast has the potential to spread. It's between all of those ducts and lobules in that fatty tissue that holds the breast together where all of the lymphatics flow. And breast cancer, for the most part, spreads through the lymphatics. So it goes from the breast to the lymph nodes of the armpit. I always consider that to be the on-ramp. Your lymph nodes of the armpit are going to be your toll booth. They're going to collect as many cells as they can to protect the rest of your body. And once the toll booth becomes overwhelmed, usually somewhere between right around 3 lymph nodes, there's a higher risk that tumor cells can hit the highway and can spread to distant parts of the body. If you have tumor localized only in the breast, we consider that to be a stage 1 disease. Breast and lymph nodes would be stage 2 or stage 3, and beyond the breast or the lymph nodes, the regional advanced area and somewhere else into the body, that's when we consider it to be stage 4. Traditionally, stage 1, stage 2, and stage 3 are all curable, and we treat patients who have stage 1, stage 2, or stage 3 disease with curative intention, meaning that anything we do before or after surgery, because surgery is the only cure for breast cancer, anything we do before or after surgery is to reduce the risk of recurrence. We know that there is definitely a difference in risk when it comes to the stage. Stage 1 risk is lower than stage 3 risk. And so we tend to treat stage 3 a little bit more aggressively than we treat most stage 1s. But we now have the ability to really personalize medicine and understand not just the genetics of the whole person and what you inherited from your mom and dad, but actually even the genetics and the behavior, the biology of the tumor itself. There are 3 main or research cell is asking, does it have a little mouth for estrogen and progesterone? Because if it does, every time it finds it in a woman's body, it eats it and internalizes it, and it's food for it to grow, divide, and survive. So one of the things we can do in that situation is to block that mouth with an anti-estrogen. So it's a targetable therapeutic option for treatment. Another thing that we always ask is, if this is the tumor cell, does it have the HER2 protein? A HER2 protein is called an oncoprotein, or a cancer-causing protein. And it sits on the tumor cell surface, and it dangles little legs down inside the tumor cell, and it has a big ball on the outside of the tumor cell. And we have treatments that we can treat and attack from the outside, and then it's called a monoclonal antibody. And it's an infusion that goes through the vein, but it targets those HER2 positive cells to then have your immune system come through and say, if you see us attached, we want you to get rid of us. So it's another targetable therapeutic option for treatment. Additionally, we can target those cells on the inside of the cell with an oral therapy. So we continue to be able to modify. When a tumor cell has none of those 3 things, no estrogen, no progesterone, and no HER2 protein, we consider those to be a triple negative breast cancer. Unfortunately, at this point in time, in the curative setting, we do not have a targetable therapeutic option for triple negative breast cancer, which is why those patients are treated with chemotherapy nearly uniformly unless they have the tiniest of tumors. So curative therapy can include chemotherapy prior to surgery. It can include chemotherapy after surgery. It can include radiation therapy. It can include anti-estrogen therapy for 5 to 10 years. It can include anti-HER2 therapy. That's a pill that you would take even after you complete all of your infusions. There are so many things that we get to look at now as we continue to make advances in this field to really personalize the medicine. So stages 1, 2, and 3 are always treated with curative intention. But that leaves a lot of women who are actually diagnosed with stage 4 disease, either immediately at their diagnosis of breast cancer or at a later time that their breast cancer comes back somewhere else in their body, weeks, years, months, however it may be, after their original treatment. In those situations, we traditionally are not able to cure those patients. I will tell you that I have many patients who are actually many, many years, even more than a decade out from diagnosis, that are still doing well. So that gives us so much hope. And I think that we will continue to see those survival statistics change as we continue to grow in clinical trials and enroll in clinical trials to be able to offer women different options. But part of those advances are really looking at the tumor cells itself. Not necessarily because they're breast cancer tumor cells, but tumor cells can have mutations within them that are specifically targetable. Just like, for example, we know a BRCA mutation, a Baraka mutation that you inherit from your mom and dad, we call that a germline mutation if it's something that's in your own DNA. We have treatments for with a Parp inhibitor, like Dr. Diaz was saying. We also have other mutations that we can target with other treatments that are approved in other settings. And we've really seen that we've been able to do a really good job in targeting perhaps the cause of those tumor growths in patients with metastatic disease. So what I want to ensure that you walk away with today is, number one, understanding what cancer is. Cancer is just a normal cell that for some reason, either a predisposition in your own DNA, a mutation in its DNA, an exposure to a toxicity, whether it's radiation, smoking, hormone, whatever it may be, that led to that uncontrolled cell growth. That cell growth continued to form a tumor. And if that tumor is localized within the inside of the duct or the lobe, stage 0, we cut those out. We sometimes radiate, and we usually offer anti-estrogen therapy to reduce the risk of developing cancer in the future. Stage 1, 2, and 3 can be a combination of chemotherapy, surgery, and radiation, and pills. And stage 4, fortunately, in most cases, we can offer pill therapy up front. But in some cases, we often have to do chemotherapy. But I want you to know that we are making strides, and this is a time of hope. We've never been in a better place to treat all stages of breast cancer and gynecologic malignancies, and really any malignancy, than we are today. I think
Thank you so much, Lauren.
Yeah.
Fantastic. So I'd like to introduce our next panelist, Dr. Gomez, a cardio-oncologist. And he's going to talk to us a little bit about what a cardio-oncologist is. This is kind of a new field for us here at Miami Cancer Institute, and a very welcome field. Many of our medications have cardiac toxicities, and it's great to have an expert like Dr. Gomez join our team and help us manage our patients. So Dr. Gomez, thank you so much for joining us.
Well, thank you so much, John. And this is one of the beautiful things we have here at Miami Cancer Institute, along with Miami Cardiac and Vascular Institute. We have this tremendous collaboration between oncology and cardiology, which only adds up to the benefit of the patients. I do have actually a couple of slides to show, meaning what is cardiology without some images. Okay. And basically, cardio-oncology comes at the intersection of cardiac risk factors, your inherited risk factors and the ones that you acquire in your life. The therapies for cancer, breast or ovarian cancer for this particular presentation, can have effects on the heart. And of course, the effect of the cancer itself on the body and in the heart itself. At that intersection, we have cardio-oncology. And it's an important problem because after a certain time, after 8 to 9 years of diagnosis, at least for breast cancer, it is known that patients will die actually more often of heart disease than breast cancer itself, especially if they get the cancer at an older age. So if you have an older person with a recent diagnosis of breast or even ovarian cancer, over time, after 8 to 9 years, you are as likely, if not more, to succumb to heart disease than actually the actual cancer. So your heart health during the course of cancer treatments is incredibly important. And just now, as Dr. Karkas already had an overview, the treatment of breast cancer really largely depends on the extent and the receptors. And here, the easy differentiation is whether you have that protein receptor, the HER2 receptor, whether it's positive or not. And if it's negative, if you don't have that receptor, and in many cases,
Dr. Gomez?
Yes.
I'm so sorry to interrupt you. Your sound, your audio is cutting in and out. Is it possible for you to use perhaps the phone to dial into the call, and that might clarify? It might be your internet.
No, I'll tell you what, I'm just gonna.
Can you hear me better now?
Yes. Much better, thank you.
Okay, so I was mentioning if many cancers, especially the triple negative ones that Dr. Karkas alluded to, and which are very common in BRCA positive patients, they will require what we call conventional chemotherapy that includes adriamycin. And adriamycin can potentially be cardiotoxic. Now, if the tumor is HER2 positive, then those patients will require Herceptin, which is a whole different, what Dr. Karkas was alluding to in terms of targeted therapy, a very specific therapy for that type of tumor that attacks that receptor, but it also has a very slight potential of toxicity to the heart. And by toxicity to the heart, we mean that it can weaken the heart. And the only way to monitor this, or the easiest way, or the most common way to monitor this, is by doing serial ultrasounds of the heart muscle, what we call them echocardiograms. Now, ovarian cancer, which is also very associated with BRCA positivity, is a different ballgame altogether. As Dr. Diaz already mentioned, most of these patients will require carboplatin and Taxol. These medications have many side effects, but cardiac-wise, it's usually not that bad compared to other medications. But then he also mentioned the immune therapies, out of which the most common one would be Avastin or bevacizumab. And this one, it does not weaken the heart, but has an increased risk for producing ischemia, producing heart attacks. So therefore, in patients that require this medication, it's very important to treat the risk factors, make sure the blood pressure is fine, the diabetes is well controlled, your cholesterol is well controlled. And if you have a lot of risk factors, patients probably need to be tested with a stress test to make sure that coronaries are fine, and we don't need to fix anything before they go into these treatments. So if you are a cancer patient with breast or ovarian cancer, but particularly breast cancer, I mean, when do you know, listen, should we talk to a cardiologist for it? Not everybody is a cardiologist. Now, most of the, especially for breast cancer, many patients will be young and otherwise totally healthy. They don't have any other risk factors, and they usually will tolerate the medications very well. But if you have risk factors for the toxicity of the medication, you probably need to be seen. And if you have age over 60, if you have a history of congestive heart failure, if you have a previous history of a heart attack, or if you have a history of smoking or high cholesterol, diabetes, you want to be seen by a cardiologist. The echocardiogram is the most useful tool that we have. It's an ultrasound of the heart, and we can see the heart pumping. We can have it in three-dimensional images, and it really makes it much easier. We have this new feature now called strain. You really want to have your ultrasounds with strain. It's like an early warning system that tells us toxicity before the heart muscle gets weak. It's an incredible tool that you really want to. By physical activity, that's the most important thing we can do. Keep active, remain active, even if you remain weak. Because of the chemotherapy, you want to keep on trying to get going. Medications have variable results so far. There's a medication called Entresto that we have a lot of hope for in terms of prevention, but the studies are still ongoing. And the treatment for heart failure, if the heart muscle becomes weak, is 4 fundamental things. Entresto, which is the one that I just mentioned, beta blockers, carvedilol, metoprolol, and medications for diabetes have shown that are fantastic for the treatment of heart failure, and then diuretics like spironolactone. A quick word on radiation. If your breast cancer requires, this is particularly for all the radiation treatments. Nowadays, the radiation is much better, but if you have extensive radiation in the left breast, it could produce coronary disease, and those patients need to be screened afterwards. So thanks for your attention. And now I think we move on to the next speaker.
Thank you, Dr. Gomez. That was a great presentation. So our next speaker is Dr. Martin Negron, who I've had the pleasure of working closely with for the last 5 years. She's been instrumental for my patients. And as we know, the recommendations are all newly diagnosed patients with ovarian cancer should be referred to speak with a genetic counselor. And recently, the American College of Surgeons also recommend that all newly diagnosed breast cancer patients speak with a genetic counselor and possibly undergo genetic testing. So she's a very busy woman, and we're grateful to have her be part of our team. Dr. Negron.
Thank you. Thank you for the invitation. And I would like to discuss some concept too. When we talk about hereditary cancer versus familial, there is a difference. When we see patients, we get a pedigree and we have an idea about how, what is the burden of cancer in the family. When we do genetic testing, because the patient meets criteria, because the patient has a diagnosis, now it's easier to get genetic testing. It's is available, it's easier, and also is less expensive, and is covered by the majority of insurance. When we do genetic testing and we cannot find an answer, but there is a strong family history, we call it familial cancer. It's hereditary when we can find a mutation that explains the cancer. Sometimes what we found is, even if we don't find a mutation, because we are doing panels, we can find that the patient carry a mutation that predisposed to something else, and we cannot explain the cancer, and we go over that information. Another important concept is somatic versus germline. Somatic, and it has been discussed previously, but I'm gonna go into the germline genetic standpoint. So when we talk about somatic, means that there is a change that happened in the cell, because all cancer is genetics, is caused by a genetic change, but only a few, and this percentage have been growing with time as we learn more about genes. At some point it was 5 to 10%. I usually quote a 15%. There is a recent paper that said 18%. As more genes are added, we learn more, then we know that the risk is higher than what we thought. The 15% of the cancers are caused by a genetic predisposition. This is a germline mutation. And then the somatic is a change that happened, and it's not in every cell of your body. It's in that cell when you have the cancer, and this is something to do with what Dr. Karkas mentioned. Germline is the one that you can pass down. Somatic you cannot pass down. However, sometimes we receive referral for patients who have somatic mutations, but the percentage of the mutation is too high. That is, there is a suspicious that is a germline what is showing. And in those cases, we need to do germline testing to confirm. It's possible that some patients are referred with a somatic that again looks so high, the percentage that we need to confirm that is not germline. Somatics is used, even if we don't find a mutation in the germline, is still a possibility for the BRCA1 and BRCA2 for the purpose of using Parp inhibitors, that a mutation is found in somatic, and there is a different type of testing that can look into that, and the patient can still be candidate. Another concept is doing a small panel versus doing a large panel. In the past, the people were tested for BRCA1 and BRCA2 only. In some cases, even the test was what is considered incomplete. Even the BRCA1 and 2 were incomplete because at the very beginning, we know about these genes in mid-90s. And until I said 2011, they were doing only sequencing, which is like a spelling test of the gene. And a spelling test of the gene will not look at the amount of genetic information. That will be another type of testing, which is the deletion and duplication analysis. Now, so if there's people that were tested a long time ago, we even have to discuss that test is incomplete, and we still may find a mutation in BRCA1 and BRCA2. I call it like that. That is the Baraka genes. People call it Baraka. There are more genes that have been associated with breast cancer. The most common is still the BRCA1 and BRCA2 genes, but there are other genes that have been associated. And this is why we don't recommend only doing BRCA1 and BRCA testing. Even if we see people that had that, we said this is incomplete, we need to do more testing. When we see a large family and we see that there are different type of cancers, we have to discuss the fact that we can do a large panel. And the benefit of the large panel is that these patients has one shot to do genetic testing. There are not many codes that the insurance accept. And we can do, is the same price of doing a small panel that include 8 genes to do a larger panel that we can do depending on the lab, could be 35, could be 87, could be 91. In the majority of cases, the patients will choose the larger panel. I talk to the patients about the importance of knowing as much as possible, but I also like to assess how much anxiety this can cause. Now, I'm glad that Dr. Joseph is here because there are some genes associated with breast cancer that are associated with colon cancer, and the most common syndrome is associated with ovarian and colon cancer, which is Lynch syndrome. The hereditary breast and ovarian cancer, the carrier frequency is 1 in 400, 1 in 40 if you're of Ashkenazi Jewish descent. The Lynch syndrome carrier frequency is 1 in 279. There are multiple people walking around, they have no idea they carry these mutations. It's common in the population, and really we still see more, maybe hereditary breast and ovarian cancer more commonly. When we do testing, we go over and give recommendations based on what we have in the guidelines. The guidelines have been moving in a way so fast that we have better numbers, better recommendations. We still have more information regarding BRCA1 and BRCA2 than other, but now we can discuss more about what is the risk for other cancer. We have new guidelines for recommendations with patients with pancreatic cancer. If you carry a mutation and you have a first-degree family member or a second-degree family member with pancreatic cancer, you will meet criteria for the screening for pancreatic cancer. And there is also more genes that we have been learning about. Another concept that I want to discuss is what is a gene and what is a candidate gene. A gene that we know is associated with cancer, we will have recommendations in guidelines. Although understand that the technology is moving very fast, therefore the guidelines are behind because we deal with people. It's not the same as the technology, the machines. They don't deal with people. We have some things that we need to follow in order to have the data, the medical data. But for those that are in guidelines, we have clear recommendations. When we do a large panel, it's possible that we also send for candidate genes. These are genes that are believed to be associated with cancer, but there is still more data needed. So what we do in those cases is that we go to the literature. We can see there are many good papers that we feel comfortable that can be used in terms of helping with the screening. In these cases, when we see positive candidate gene, we provide all the information that is needed for the letter of medical necessity in order to get the screening, as long as the data is good in those papers. Something also important is that some of these mutations, if you carry one mutation, is associated with cancer. But if there is 2 mutations, then we're talking about recessive conditions that tend to be more aggressive. When we talk about the BRCA1, when there is 2 mutations with the BRCA1 mutation that is not compatible with life, there will be multiple miscarriages in people who had 2 mutations. It would be if mom carried a mutation, dad carry a mutation, there is a 25% chance of having a child with the 2 mutations that is not compatible with life.
Thank you, Annalise. I was going to say, thank you so much. There's so much information when it comes to genetics. That's why we have so many of our patients go and have such an extensive consultation with you guys. It's so important that you provide. So we do have time for question and answers later, but I wanted to get to our next panelists. So thank you so much again for all that information. Our next panelist is Dr. Joseph, and she'll be speaking about kind of picking off what Dr. Martin Negron spoke about on the GI-associated cancers with both hereditary breast, ovarian, and uterine cancers. And so I'd like to welcome Dr. Joseph. Thank you so much for making the time today.
No, thank you so much, Dr. Diaz, and thank you, Tracy, for the invitation. Greatly appreciated. So I know we touched upon some, BRCA-associated breast and ovarian, but I want to shed some light onto if there's any associations with gastrointestinal cancers. So one of them would be pancreatic, and pancreatic really has a high mortality. So if it's something that we can catch early, it's something that we can potentially cure. So in the grand scheme of GI cancers with the population, there's been an incidence of about 22% that it has increased to diagnose these patients under the age of 50. So more and more, we're seeing younger patients with these GI cancers. And in relation to breast, it's about 3.6 times more that these patients will die from their cancer than in comparison to breast. So when I look at BRCA1, for example, there's 2 times the risk of developing pancreatic cancer versus 3.5 times the risk with BRCA2. So it's very crucial to spread the awareness and the education to see what we can do to prevent this from being diagnosed and from it happening. So what can we do? What are the signs and symptoms of pancreatic cancer? A lot of the times it's nothing. So the biggest symptoms that my patients will have is I've had unintentional weight loss, which is a very non-specific symptom, especially if patients are maybe exercising, they're eating a little bit better, but the weight loss is, it exceeds more than what should be. In addition to that, when the symptoms have progressed a little bit too far, patients come in and they say, you know what, I look really yellow. And at that point, that's when the pancreatic mass tends to impinge on our hepatic, structures, and patients become very jaundiced. So at that point, we do CT scans, MRIs, we do biopsies in order to get the diagnosis. So what can be done to prevent this, for example, for our BRCA mutation carriers? There is some data that have shown that we can alternate with what we call an endoscopic EUS, so an endoscopic ultrasound, and an MRI. So an endoscopic ultrasound is really a scope that visualizes the pancreatic and your biliary tree to see if there's any cyst, any lesions, anything worrisome. And at that point, if anything that we see is greater than 5 millimeters, then we would recommend to get a biopsy to elucidate what is happening. If everything is negative and everything looks beautiful, then in 6 months' time, then we would recommend an MRI of the abdomen. There really is no consensus of how to do that. So when we look at these 2 screening modalities, I think alternating this at a time frame of about 6 months would be the best to educate our patients to do. And like what Dr. Karkas was mentioning with breast, a lot of the times our pancreatic patients, the way that we diagnose it is if they're resectable or if they're not resectable. And resection is the only chance that we can offer these patients a cure. So we offer neoadjuvant chemotherapy, which is chemotherapy before resection, that we kind of throw all our heavy guns in if it's a pancreatic adenocarcinoma, because it is one of the cancers with the highest mortality. So it's something called FOLFIRINOX, but we do have a lot of clinical trials at MCI that we are trying to elucidate the best type of regimen for these patients. So a little bit of chemotherapy and hopefully surgical resection to get these patients to a cure. So the other brief cancer that I wanted to mention is colorectal cancer. Now with the BRCA1 and 2, there is no definitive, I guess you can say there's some controversy about the association with these genes, but the more and more that I see patients, the more that I see them with Lynch syndrome, for example, that there is some data for BRCA as well. So what is the screening? And recently it has been changed that with the American Cancer Society, screening has started at age 45. So screening, you could do a fecal occult, but if that fecal occult is positive, then the gold standard is colonoscopy. So something that I'll always recommend patients is just go straight for the colonoscopy. So now with screening, I think with COVID, a lot of our patients haven't done many screenings. So the old statistics used to be 1 in 3 US adults just haven't done screening, but I'm sure that has increased now with COVID. So one of the things to prevent these cancers is screening. So I can't be a bigger advocate for colorectal cancer to get screening at age 45. And one of the neat things, I guess, with colon cancer is that even if it was diagnosed at a later stage, so for example, a stage 4 where you have maybe a liver met or a lung lesion, those patients we can still offer a cure if we can get them to resection. So again, pancreatic cancer, colon cancer have huge associations with hereditary breast, and I think the biggest thing is to work as a group, a multidisciplinary group. At MCI, we even recently opened a genetics GI clinic that's being spearheaded by both of my colleagues, Dr. Parp and Dr. Diaz, and to work with the entire group that we see here today. So thank you for having me.
Thank you so much, Sarah. And thanks to everyone. There's so much knowledge. We got to get everything in on time. And we had a bunch of questions come through. So I'm going to start asking some of these questions. The first one is for you, Sarah. And the question is screening still available at MCI during the pandemic?
Screening has never stopped. So it's always available, but I think the numbers that we've seen, a lot of patients are scared to come within the hospital. So everyone, has safe practices. Everyone washes their hands, we wear masks. So yes, there is screening that, we can always offer patients.
Great. And the next question is for Lauren. If I have a family history of breast cancer, when should I start getting my mammograms?
So that's a multifactorial answer. So number one, if you have a strong enough family history that you should undergo genetic counseling and potentially testing with somebody like Dr. Martin Negron, that might impact the age at which you start. But in the absence of a genetic mutation, we typically say that you would start 10 years prior to the youngest case in your family. Fortunately, I think that the more and more that we have talked about malignancy in society in general, and we talk more about just cancer and the fact that if you talk about it and you understand the family history, then you might be able to prevent poor outcomes. I think that we're finding more and more people, especially among cultural barriers, talking about it and seeking out that information in order to start their screening on time. But typically, for the average risk woman, it's age 40. If you have a strong family history, you should be considered for genetic testing, as that will impact the age at which you start. But otherwise, you would start at 10 years prior to the youngest diagnosed breast cancer in the family.
Lauren, just to follow up on this, what kind of screening should patients undergo? So there's been some talk about a 3D mammography. Can you talk a little bit about what that is and what do you recommend in your practice?
So I think in general, that's what most people offer now is the tomosynthesis. It's basically a 3D mammogram, and it overcomes a lot of the issues with density that traditional mammography had. If you think of what a traditional mammogram is, it's an X-ray. So the way that I always explain this to my patients, most people have seen either the X-ray of a hand or an X-ray of a leg. If you look at the bone shows up very dense and white. If you look at the muscle's kind of like a gray tone, and then you've got the fat. The fat is very dark and see-through. So a fatty replaced breast, it's very easy to find cancer because cancer shows up white. But in a dense breast, in a field of white, dense breast tissue, and you're looking for white cancer, which are little calcifications, it's like looking for a needle in a haystack. So in general, tomosynthesis is what most insurances pay for and what most screening is. We do have recommendations to do an ultrasound in patients who do have very dense breast tissue. This is more common in younger women or women who have never lactated, that they might have a little bit more increased density because our breasts do fully mature at lactation. But that might also be a useful tool. If you're high risk, meaning that you have a calculated risk greater than 20% in your lifetime, and maybe that is due to family history, maybe it's due to starting your period early through menopause late, so a longer exposure to hormones over the course of your life, or maybe it's due to prior biopsies with some atypical cells. Whatever it might be, if you have a high risk, then we screen people on a high risk screening protocol, which would alternate between mammography and 6 months later MRI. Because if you do have that higher risk and we're looking more frequently, we're typically going to find it when it's a very small and early stage with less long-term impact.
Great. Next question is for Alvaro. The question is, what can be done to protect my heart during radiation therapy? I assume that's for radiation therapy for breast cancer, but
yeah, so nowadays radiation is so much more sophisticated that the risk is very small. unless you require very intense doses of radiation. But usually, the best thing you can do is go to a center like MCI, like Miami Cancer Institute, that has the latest in radiation technology. So the radiation really is targeted towards the breast tissue. The risk for coronary disease and radiation really comes mostly in patients that had radiation a while back, 15 to 20 years ago, where the beam was not as targeted as it is nowadays, and it could affect the coronary arteries, and even the aortic valve. You know, some patients can have aortic valve disease. But nowadays, really, I mean, there's nothing you can do but to go to a center that can give you a targeted therapy for breast cancer. There's really no other way to protect yourself from it. It's the only way.
Perfect. The next question is for Arelis. Can patients under the age of 18 get genetic testing?
I will not recommend unless there is, it's depending on the gene. If we're talking BRCA1, BRCA2, and the majority Lynch syndrome genes, no, it's not needed. I actually don't recommend, because I think that the person who gets tested need to know all the information. Also, we discussed the Genetic Information Non-Discrimination Act. And for that is that there is protection in the law against discrimination for health insurance, but not life insurance and disability. So these individuals need to do that first before, if it's something that is interesting to them, to do it before doing the genetic testing. Also, you want the person to have all the information, and and to be able to digest all the information, to have the maturity. In the perfect case, I will test people with BRCA1, BRCA2 mutations at age 25 is when their medical care change. So ideally, you get tested when the your medical care change. You also look at the family history, because when to start screening change depending what is the earliest cancer in the family. And also for some genes like TP53 and some of our rare genes that are not associated with breast and ovarian cancer, we test early, but it's because of the screening. And we will discuss that at the moment of the result discussion.
Thank you. And along those lines, is genetic testing covered by insurance?
It's covered by the majority of insurance. They cover for the BRCA1 and BRCA2 and the Lynch genes only. But then because we can add all these other genes that are important, it's just that the insurance is always behind. And there are many guidelines for genes that they don't cover. Because of the availability of panel, we can send for multiple genes, but it's definitely covered by insurance. And even if it's not covered by insurance, because there may be a clause, or maybe because you have genetic testing in the past and we cannot do uptake of the testing, the price is very affordable. It's $250, and there is payment plan. Really, in the past, the cost of genetic testing was a deterrent. It's not anymore.
And this is for my two medical oncology colleagues, Drs. Joseph and Carcass. Are certain cancers more likely to metastasize, and is that related to a genetic link?
I'll let you, or it's up to you.
Go ahead, go first.
Oh, okay. So from what I've seen and from what I've practiced, you know, the point that when the cancer cells invade the basement membrane, which I guess is the definition of a cancerous cell, then it has the potential to metastasize. So I've seen certain cancer types have certain predispositions for, you know, for example, prostate likes going to bone, prostate likes going to liver, pancreatic likes going to the liver, so does colon. So I've seen certain primary tumor have a predisposition to going to certain sites, but is that linked to a gene link? To date, I don't think I've come across anything to be 100% certain about that.
So I would say the same. We know that really stage is the bigger indicator of the risk of metastasis. I think that in many ways, some of our hereditary cancers, particularly in the breast realm, it might impact our treatment decision, and it might impact which agents we use in chemotherapy, because we know that a normally functioning BRCA gene, I always think of it like a spell checker. It basically fixes DNA damage on the spiral staircase of the DNA, and it fixes both sides of it. And when you have an impaired BRCA gene, it can't fix the DNA as efficiently. So sometimes we choose to use DNA damaging chemotherapies because we know that it's basically kicking it in its weak spot. So it might impact our treatment decision, but I do not feel, in fact, I would argue that I feel that a lot of my BRCA patients actually do better when we know that that's the mechanism of their cause of disease. So no, I don't think that it's really a predictor of metastasis. Unfortunately, patients, all comers for a diagnosis of an invasive disease always has a chance of metastasis. The likelihood decreases with earlier stage, but I actually feel like my hereditary mutation carriers often do better because we know kind of the cause, the underlying cause of their disease.
Question came in, at what age can I stop getting my pap smears? And the answer is, it depends. So the guidelines are changing again. In the past, you used to continue to get your pap smear indefinitely, and now we do it kind of on risk base. So if you underwent, let's say, a hysterectomy for benign fibroids, and you never had an abnormal pap smear before, the recommendations are you don't necessarily need to keep getting your pap smears going forward. The recommendations had also been that, again, if you had a negative pap smear history, that at age 65, you could potentially stop getting your pap smears. I can tell you that most primary care physicians and most gynecologists don't follow those guidelines, and that's okay. And the new guidelines, which will be coming out, will probably amend that, in part because we know that there's a bimodal distribution of cervical cancer, and we see it in our elderly population. And so we perhaps are missing that ability to screen those patients. Also, we're living longer, and people are having lives and second marriages, or kind of a new honeymoon for their life later in life. So what used to be a monogamous relationship with no further HPV exposure, now we have second marriages, and then we're seeing a rise in elderly patients having new sex partners, or potential new HPV exposures. So I think those guidelines are going to change, and I think it's a discussion to have with your gynecologist and see what is your past pap smear history and what are potentially your risk factors going forward.
John, I'm just going to comment real quick on that also, because a ton of patients always ask me when, I'll have a patient who's 85 come in, but plays golf 3 times a week and is still very active. And they say, oh, well, I haven't been having mammograms because I was told I don't need them anymore. I am of the opinion that if you are healthy enough, or you would undergo an intervention to remove a cancer, being colon, being GYN, breast, continue with your screening. You stop your screening when you decide that you are never going to do anything about it if you were diagnosed. But I don't think that there's a real stopping point. We're living longer, we're healthier. I think that there's no time to stop until you decide that you wouldn't do anything.
Yep. Next question comes in for Dr. Negron. My identical twin sister had triple negative breast cancer, but was never able to undergo genetic testing. Should I get tested?
That depends. Well, it's at what age the triple negative? Yeah, I would say that you can do genetic testing now. If it would be covered by insurance, it depends on the age of your identical twin had genetic testing, had the cancer. Triple negative are associated with BRCA1, but it can be seen in other type of mutations or genes mutations. I will definitely recommend the consideration of testing. And I want to say something else also when you were talking about metastasis and genetics. For prostate cancer, that is part of BRCA1 and BRCA2, and in reality for many of the genes associated with breast cancer, but I'm talking about BRCA1 and BRCA2 now, they tend to be Gleason 7, and Gleason 7 tend to metastasize and be more aggressive. So that is a link with a gene that if it's mutated, the probability of metastasis is higher.
Great. This next question is for Tracy. Tracy, what resources does BRCA Strong provide for women with breast cancer?
What we're providing now is the pre-mastectomy care packages, which include, like I said earlier, a post-mastectomy bra, 2 pillows, a robe with a drain belt, as well as one-on-one with other women to advocate you through your journey, whether it's the same diagnosis or somebody on a similar path. Just connecting with you guys and making sure that we're keeping up to updated information, especially with clinical trials, sharing different information, sharing different stories, as well as we offer a program called Bras for Brave Beauties, which is a program for lymphedema sleeves and bras.
Thanks, Tracy. So this next question is for my medical oncology colleagues and also Dr. Gomez is, if I have heart disease at the time of my cancer diagnosis, would that require different treatment protocols?
Well, that's an excellent question. And it depends on what cancer we're talking about. Obviously, if you're going to require medication that can weaken the heart, you really need to be assessed. If you have a history of heart failure, for instance, you need to have an ultrasound of the heart to see if your heart is strong enough for the medication. Certainly, if your heart is already weak to start with before you get any chemotherapy, therapies with adriamycin and Herceptin will usually be contraindicated. And there are other mechanisms, there are other therapies that can be used, but those two probably you want to stay away from. Now, the other question is, if you have risk factors, if you had a history of coronary disease, of a stent, if you have high blood pressure, if you smoke, if you're over 60, those are the type of patients where you really want to see if a cardiac oncology can see you, because then you're at higher risk for sure for developing complications. So it depends on the treatments that you're going to get. It depends on what your cardiac problems may or may not be. Like I mentioned, for instance, for ovarian cancer, if you're going to get immunotherapy with Avastin, and you have a history of smoking, high blood pressure, you want to be screened. You may want to have a stress test before you get Avastin to make sure you don't have any coronary blockages. So again, it depends on what the therapy will be and what the effect of that therapy would be on the heart and what your own risk factors are as a patient before the chemotherapy even starts.
Correct. Just to chime in, whenever on my first consultation with patients in the office, if they do have anything concerning that would put them at elevated risk to develop cardiotoxicity from treatment, I refer to Dr. Gomez. So we work very close hand in hand.
And I agree. I always look at my patient. That's what's so helpful about seeing people in person, right? In this world that we've had so many virtual visits. When you see a patient with a new diagnosis, you can actually examine them, get a real feel for their overall health. And we understand the stressor that chemotherapy is. And in some cases, the risk-benefit ratio is in favor of treatment. In other cases, you're right on the line, the fence of whether or not that type of treatment and that potential risk to the heart is really in the patient's long-term benefit. But I always do encourage, particularly in patients who do have cardiac risk, that either they continue to follow with their oncologist or their cardiologist that they are already established locally, or they are referred on to cardio-oncology as well.
And I cannot overstress the importance of the collaboration amongst all the specialties that we have here. This is a phenomenal panel, by the way. And I hope the audience is really getting all the benefit. But there are times actually when we have, for instance, a patient that's responding really well to the chemotherapy and they really are doing fantastic. The tumor is almost gone or gone completely, and the heart becomes a little bit weak with therapy. We can give medications, support the patient, and tell the oncologist, listen, keep on going because the patient needs that chemotherapy. At the end of the day, my job as a cardiologist is to make sure that the chemotherapy can continue, but can continue in a safe manner. Because at the end of the day, what's going to cure the patient at that moment is going to be the chemotherapy. So that is part of my duty, and that's where the collaboration really comes along fantastic, because we really work very well hand in hand between the two institutions to make this happen.
Next question is for Dr. Joseph. Is there a relationship between colon and ovarian cancer?
So, Doc, I think genetically speaking, yes. Do I have a lot of colorectal patients in my clinic that don't have ovarian? Yes. Do I screen them by doing tumor markers? On occasion, I do. However, baseline testing on all patients that come in with a new diagnosis of colon and pancreatic, we do genomic testing. So if there's any, certain gene mutations like PALB2 or ATM or BRCA, then we work hand in hand with genetics, and then we do that established screening and see what the best route would be. However, at this time with my patient population, I haven't seen any dual concurrent diagnosis of colon and ovarian. I'm not sure if any other panelists have seen that. If anybody else wants to chime in.
Arelis, do you want to comment about Lynch
Yes,
syndrome?
yes. Yeah, there is in hereditary cancer, yes, is Lynch syndrome. It will be, Lynch syndrome is associated with an increased risk for colon and uterine and ovarian cancer. Not all the genes associated, there are 5 genes that have been associated with Lynch. MLH1, MSH2, and MSH6 are the ones that are with ECAN, that works with MSH2 are associated with ovarian cancer, PMS2 no. And that will be the main link. And that is the one that I said is not uncommon to find mutations. Let me see, you said ovarian and colon. Yeah, I think that will be the one, Lynch syndrome.
Thank you. And this next question is for Dr. Karkas. If I haven't had cancer, but I test positive for a breast cancer related mutation, does that mean that I have cancer?
No, it does not mean that you have cancer. It means that you potentially have a predisposition to developing cancer, and we would modify your screening, but it does not mean that you have cancer. That's really kind of where this whole definition of a survivor, meaning that you have been diagnosed with cancer and you have been treated and you are now in the survivorship period, versus a previvor, meaning that you are predisposed to the development of malignancy. So maybe you decide to take on prophylactic procedures or whatever it may be to reduce that risk of developing cancer over time. We call those previvors. But really a previvor is anybody that has been diagnosed and with a mutation and a predisposition, but not malignancy. We just know that it puts you at a higher risk for developing that cancer over the course of your lifetime, but you actually do not have a diagnosis of cancer.
Thank you. Arelis, if I had 23andMe and there was no evidence of a genetic mutation, do I need to see a genetic counselor?
23andMe only look for the 3 Ashkenazi Jewish mutation. If you're not Jewish, it doesn't work. It doesn't say nothing to you. And also because there are other genes, even if you're Jewish and no mutation has been detected, if there is a strong family history, or if you have any questions, really just make the appointment with genetics, because what they offer is very minimum, and that is. I feel that many people are not aware and give them a false sense of security, but only if you're Ashkenazi Jewish mutation, the 3 Ashkenazi Jewish mutation, but those are not the only genes associated with cancer, and there may be other mutations even in the BRCA1 and BRCA2, even if you are of Ashkenazi Jewish. So the answer is yes, do genetic testing. I'll come to see genetic counselor.
So I want to thank our panelists today. Every time I hear them speak, and I've heard many of them speak many times, I always learn something. I'm very blessed to work with such great collaborators here at Miami Cancer Institute, both at our main campus down in Kendall, as well as our campus here in Plantation. I want to thank Baptist Health for setting up this program and for continuing to get experts out an ability where they can reach not just one patient consultation, but so many patients. And I want to thank Tracy and BRCA Strong for their continued support. This really is a grassroots organization that started because, as Tracy said, when she was diagnosed, she found a lack of resource, particularly for young patients. And so in my consultation, I make my patients take out their cell phones and I make them look up her Instagram, her or her Facebook page and make them aware of this. It's such a great resource. I saw a patient yesterday I was talking to about Tracy's organization. She took out her phone, she brought up the IG, and she started to cry because she said, finally, I have someone my age that I can reach out to and talk to someone who really knows what I'm going through. So thank you, Tracy, for all that you do. And Tracy, if you want to just end us on a couple of words. Again, thank you everyone for joining us. Thanks to all my colleagues for making time on a busy Friday for such an important program.
Thank you, Dr. Diaz, and thank you to all of our panelists today. I'm truly grateful and honored to work with such an amazing team. Like Dr. Gomez said, going to a multidisciplinary center where we can find everybody together under one roof and work together and collaborate, where we know if we go see Dr. Karkas and we need to see genetics or we need to see a cardio-onc, like we can all go under the same roof and have the communication. And this is what patients need to see and know that's out there, that centers like you guys come together to make a difference in our community and making sure that the resources are available. So I really want to thank you guys for the opportunity. And if we can help anybody out there, you guys can go to our website, www.barakastrong.org, or you can find us on Instagram. And remember, you're not alone and we're here to support you. Thank you again.